Recording has started.
Good afternoon, everyone. Welcome to the Clinical Trials Methodology Courses webinar series. Can everyone hear me? Can you nod? Sharon, can you? Okay, perfect. Today's webinar is titled Sample Sizes. You are all muted upon entry, so if you do have a question, please click on the audio icon to the right and unmute yourself, or you can type it in the chat at the top right of your screen. Lastly, please evaluate the presentation after it's over via the evaluation link located in the chat. So today's presenter is Dr. Sharon Yeatts. Dr. Yeatts is an associate professor of biostatistics with the Data Coordination Unit in the Department of Public Health Sciences at the Medical University of South Carolina. The Data Coordination Unit is an NIH-funded statistical and data coordinating center that specializes in the design and coordination of multi-center clinical trials. Dr. Yeatts has trial experience in the treatment of ischemic stroke, intracerebral hemorrhage, and traumatic brain injury. She is the PI of the Statistics and Data Management Center for the Phase 1 and 2 trials of deferoxamine in ICH and the PI of the National Data Management Center for Diffuse-3, a multi-center clinical trial using an adaptive design to assess the efficacy of endovascular therapy following imaging evaluation in ischemic stroke. In addition, she was the primary unblinded statistician for the large Phase 3 trials of the Interventional Management of Stroke, IMS-3, and progesterone in traumatic brain injury, also called PROTECT. So Dr. Yeatts serves on data and safety monitoring boards and as a grant reviewer for several funding agencies, and her primary interests include the development and implementation of efficient early phase trial designs and novel trial outcomes. So thank you very much, Dr. Yeatts, for presenting today. I'll turn it over to you.
Great, thanks, Joy. Can everyone hear me okay?
Yeah.
I guess, perfect. So I appreciate that introduction. Rather than the title of today's talk is sort of generic sample sizes, I'm not actually going to talk to you about how to calculate sample sizes. I don't think the expectation is that you're going to leave and start doing this on your own. Really what I want to talk to you today about are what are the things that you need to know when you have that meeting with your statistical collaborator to come up with a sample size. A lot of times that is a very disjointed conversation with both parties having different expectations, and hopefully this will sort of initiate you into how those conversations might go, what sorts of things your statistical collaborator might ask you, and what sort of information you might want to have on hand. I do have a couple of disclosures. Either this year or in the past couple of years, I have received consultant fees related to PRISMs for my role on the steering committee, and the department has received consultant fees for my role on the DSMB of Intrepid. But I'm not actually going to talk about any information on unlabeled use of anything. This is going to be sort of a methodology talk, but I'm not going to be, there's no formulas, I don't think. Hopefully it will be sort of a very intuitive discussion. So I want to start by sort of playing a tongue-in-cheek video for you, which is going to sound very silly, but many of the statistical collaborators you will work with, including those who are helping to lead your small groups, have had conversations that go that go a lot like this.
I have a study and I need to know how many patients I need. I think I only need 3 patients.
Okay, what kind of study is it?
I'm doing a lab study. Can I just use 3 patients?
That depends. What are you trying to show?
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable that measure is?
We always use 3 patients. That is what we have published before.
3 patients per group or in total?
Yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A and control, and drug B alone.
Oh, how many groups are you analyzing altogether then?
My grant is due tomorrow. I just need to know if I can just use 3 patients per group.
Okay, well, you probably should have come to me earlier for help with this.
All I need you to do is tell me that 3 patients are okay.
So, it is not that easy. Your marker for apoptosis may have a large amount of variability associated with it that could make it difficult to ascertain differences based only on 3 patients per group. It also depends on what kind of outcomes you are looking at. Are you looking at normalized changes in expression levels from baseline? 3 patients may not be sufficient to detect differences in these expression levels between the different treatment groups.
I do not understand.
I'm saying that you may need more than 3 patients per group, but that I need more information to determine that.
The serine protease granzyme B is made in cytotoxic lymphocytes, where it is inactive due to the low pH of the storage granules. It is measured immediately upon delivery into target cell cytoplasms, where the pH is neutral. This is followed by cleavage of phase 3 by granzyme B in the target cell cytoplasm and the subsequent induction of apoptosis. All proteolytic events can be quantitated at the live single-cell level by flow cytometry and imaged by optical microscopy.
I understand very little of what you just said. Maybe we should talk more about this.
I just need to know if 3 patients are enough. My grant is due tomorrow.
We will need to meet to better understand this before we can determine the appropriate sample size.
I can put you on my grant for 0.5% FTE. You can design and analyze the data later.
Do you really think that is enough to do the work?
Well, it may be less if it is awarded and the budget is cut.
Please go away.
Okay, so as I said, many of us have had conversations that went a lot like that, although none of the statistical folks you're working with through the clinical trials course, I'm sure, would ever tell you to go away. But it does do a nice job of demonstrating that there is this disconnect between our backgrounds and how we speak about things. And so, again, this talk is really sort of focused on getting us to the same page so that there's an understanding as to what is really needed in order to come up with that initial sample size calculation. And it really is an initial sample size calculation. In many instances, there's a lot of back and forth before the final sample size is derived. Okay, before we get started, I'm going to make a disclaimer, which is that there are lots of different trial designs, there are lots of different methods of analysis, and I could spend a whole semester talking to you about how to come up with sample sizes under various conditions. And we only have 40 minutes or something like that. So this talk is geared towards the design of a superiority trial. And I don't necessarily mean a phase 3 confirmatory efficacy study. When I talk about a superiority trial, I really just mean any 2-arm randomized trial where you want to show that one treatment is better than the other with regard to some primary outcome. And the assumption here then is that the deliverable is the p-value from your hypothesis test. There are lots of other trial designs. The objective of those might be something other than superiority. You might be trying to establish futility. You might be trying to establish non-inferiority. You might not want the p-value from a hypothesis test at all. You might be interested in estimating the precision of some measure or of selecting among a variety of interventions, one which will move forward to further testing. Or you might be interested in selecting some optimal dose of a given drug. And in those cases, some of the things that we're going to talk about here are still going to be relevant. Some of them will not be relevant at all. So again, it's important to sort of have that design in mind and have the objective of your study in mind when having that initial meeting. Okay, why do we worry about power and sample size? Well, the true, correct, very sort of theoretical answer is that it provides us some assurance that the trial has a reasonable probability of being conclusive. We're asking the funding agency to come up with money to support this research, and we want to be able to know that we have the sample size that is necessary to answer that question with some reasonable confidence. We don't want a sample size that's too large, because then we're not allocating resources appropriately, right? If one investigator requests funding for a study that's twice as large as he needs, that money is being unnecessarily spent when it could go to another investigator's research program. And of course, there are some ethical issues. If the study is too large, then you're needlessly exposing subjects to an intervention when you could know the answer already with fewer subjects. And if it's too small, then we have the potential that we're going to get to the end result and we're not really going to believe that it's true, which really means we shouldn't have done the study anyway. Okay, so that's sort of the theoretical answer. The real answer, the easiest to interpret answer, I think, is to think about power and sample size as it's going to impact your conclusions at the end of the day. And I'm going to demonstrate this with an example. So in 2015, the New England Journal of Medicine published a paper on the therapeutic hypothermia after out-of-hospital cardiac arrest in children study. And the population here is children with cardiac arrest who required chest compressions for at least 2 minutes and remained dependent on mechanical ventilation after return of circulation. The children were randomized to either targeted temperature management or via therapeutic hypothermia or therapeutic normothermia for 120 hours. And the primary outcome was specified as survival with a good neurobehavioral outcome at 12 months. The trial was powered to detect an absolute effect size of 15 to 20%, so 15 to 20 percentage points. And based on that, the sample size that they concluded was required was 276 children, okay? When the results came out, the primary outcome was observed in 12% of the normothermia arm and 20% of the hypothermia arm. So that's an effect size of 8 percentage points. That's a pretty, in my mind, that's a pretty large effect, especially when we're talking about survival in this patient population. But the p-value was 0.14, right? Not anywhere close to what we would typically use for our level of significance. And so the conclusions were appropriately reported. In comatose children who survived out-of-hospital cardiac arrest, therapeutic hypothermia did not confer a significant benefit in survival with a good functional outcome at 1 year. And that's likely a pretty disappointing finding, right? But in the discussion section, they admit, they agree that one important potential limitation is that they cannot rule out an important clinical benefit. Okay, so despite the fact that the p-value was bigger than 0.05, they saw this 8% effect estimate, and they're saying that's potentially a clinically meaningful effect. And so a larger trial, had we done one, might have detected or rejected something even smaller. So this is really what we're trying to avoid. When we're designing clinical trials, we want to design them to target appropriate power for what is considered to be the minimum clinically important difference or the minimum scientifically important difference. And if we do that, then we can feel pretty confident that if we don't make a significant finding, that it's not worth considering this further, right? And that's the goal here. We don't want to get to the end of the study and say, gosh, if we'd only had more patients. So what are the factors in determining sample size? We're going to talk today about level of significance. We're going to talk about power. We're going to talk again about the minimum scientifically important difference and how those things play against each other to impact our sample size calculation. We're also going to talk about the variability in the response, because you have to know that in order to come up with a sample size estimate. We're going to talk a little bit about experimental design and how that can impact our calculation. So first things first, what's the research question? I'm sure in your small groups, you all have spent some time talking about this. The research question, when you meet with your statistician, should be able to be stated in the form of testable hypotheses. And so there are some key components of that that you want to have sort of stated right out front. My preference is to have them sort of staring at you from the AIMS page so that I don't have to go digging to figure them out. I want to know what's the population. I want to know what's the response variable. Don't just say, I want a 10% improvement in outcome. What is the definition of that outcome? What are you comparing? Are you comparing an active group to a control? Are you comparing pre to post? Again, you want to try to help the reader and not have them have to dig to find this information. And at what time point are you looking at that outcome? Are you evaluating, say, the modified Rankin scale longitudinally over the course of a year, but only interested in the 3-month time point as your primary outcome? That all of this should be stated because it's going to impact how things move forward. Okay, so in the case of your statistical test, we have 2 states of nature. We assume one of them to be true, and those states of nature are reflected in the form of statistical hypotheses. I'm going to start by talking about the alternative hypothesis because I think it's easier to state the alternative. So simply speaking, the alternative hypothesis is what you want to be able to conclude at the end of the study. So in most cases, if you're doing an intervention, randomized trial testing an intervention, you want to be able to conclude that the intervention affects outcome. That's your alternative hypothesis. The null hypothesis is sort of the converse of that, right? That's what you want to be able to contradict with the data. So if your alternative is that the intervention affects outcome, your null is that it does not, okay? And statistics is set up in such a way that what we're really doing is proof by contradiction. If you took some advanced math classes in college, you remember that proof by contradiction is one of the ways that you can go about proving or disproving a mathematical statement. So we conceptualize nature as being in one state or the other. Either the null hypothesis is true and the intervention does nothing, or the alternative hypothesis is true, it does something. The state truth can only be under one of those conditions. And we design an experiment and we collect data from the real world. And if the data clearly contradict the null, then we have to believe the data and conclude that the alternative is true. But if there's not sufficient evidence to contradict the null, then there's no need to believe that more complicated explanation that the intervention is doing something. So if random noise or chance can account for what you've observed in your data, then you stick with your preference for the null hypothesis. Now, because we have these 2 hypotheses, we actually also only have 2 decisions that we can make. And I'm stressing this a little bit because I often see that those decisions are worded not quite the way they are intended. So the null hypothesis can either be true or false. Those are the only 2 options. And the decisions that we make are based on the null hypothesis. Either we're going to reject it or we're going to fail to reject it. We don't accept the null hypothesis, okay? And if you want to prove your null hypothesis is true, then that's not really your null hypothesis, and we have to completely rework the paradigm that we're operating under. So we have that the null hypothesis is true or the null hypothesis is false, and we can either reject or fail to reject. And so what we wind up with is this nice little 2x2 table that shows us what the 4 possible outcomes of your trial are going to be. Okay, 2 of them are correct decisions, right? If the null hypothesis is false, meaning your intervention works, and you reject the null hypothesis and conclude that the intervention works, then that's a correct decision. And we get very excited about that. You get to write papers and go to conferences, and it's a very exciting finding. If the null hypothesis is true and you fail to reject the null hypothesis, it's still a correct decision, although potentially not as exciting, right? There is, to some extent, publication bias in the literature. It's harder to get non-significant findings published, potentially. And so it's not as exciting, but it's still a correct decision, and we should be happy about that. The issue is that we have these two errors, right? Because we never know which situation we're in. We have these two potential errors that we could make, and we want to try to limit the likelihood that we're going to make either of those. So if the null hypothesis is true, meaning your intervention does nothing, and you reject the null and conclude that the intervention works, that's what we call a type 1 error. And we restrict the likelihood that we're going to make that error by fixing the level of significance for the alpha level to be something small, okay? We'll talk in a minute about what that means, that it's something small. But that's how we restrict the occurrence of that error. If the null hypothesis is false, meaning the intervention works, and we fail to reject the null hypothesis, that's also an error. It's what we call a type 2 error, and it's related to the power. And so we actually restrict the likelihood of making a type 2 error by setting the power, targeting the power, to be something high. Okay, so how does this play into the sample size? We know the power plays into the sample size. How does the level of significance matter? So the interpretation of the level of significance is that even if the null hypothesis is true, even if your intervention does nothing, you're going to conclude that it works alpha times 100% of the time. Okay, so you have to pre-specify that in the trial design stage. You can't get to the end and then decide, I want to use this alpha level. Many times alpha 0.05 is seen in the literature. There is nothing magical about that number. It should be based on how often you're willing to accept a false positive, and how willing you are to accept it may very well depend on what sort of intervention you're testing and what sort of outcome you're trying to induce or prevent. So we can think about how this is going to impact the power and the sample size by envisioning what the distribution of test statistics might look like, or the distribution of effect sizes even might look like under the null hypothesis, right? So you know that if you were to do the trial 1,000 times under exactly the same conditions, you wouldn't get the same effect estimate or the same test statistic with every trial. There would be some variation, and you can use that information to come up with what the distribution of those values would look like. But you would expect that that distribution would be centered around 0, because if the intervention doesn't work, then there should be no difference in the means or in the proportions or whatever it is that you're testing, okay? So if you are willing to accept a false positive 10% of the time, what we're really doing, and I'm showing you, the graph that I'm showing you here is actually a one-sided level of significance. So what we're doing is we're saying, okay, I want to find the threshold beyond which 10% of the values would fall. Okay, so the shaded region represents roughly 10% of the curve that I'm showing you. And so any test statistic which is in that shaded region would be considered significant. Okay, as I decrease the level of significance, that shaded region gets smaller, right? So I'm reducing the likelihood that I'm going to make that type 1 error. And right here, I'm just showing you the shaded regions for those 3 levels of significance are overlapped, so you can see how they change. And why does that matter in terms of the power? I'm going to show you in a minute. The power is the probability that a statistical test is going to reject when it should, basically, okay? Now, the important thing to remember here is that power is specific to a given value under the alternative. So you can't say we have high power and not say for what effect size. You have to specify an effect size that you're targeting. And of course, the power is related to the sample size. If we change the sample size, the power will change. So how does the level of significance impact the power? What I'm showing you here in this graph is now 2 curves. The one on the left, again, represents the null hypothesis, where the intervention doesn't do anything. The one on the right is a potential distribution under the alternative hypothesis, where the intervention does cause a change. And what I'm going to show you is that the power is essentially can be thought of as extending the shaded probability that we just talked about for the level of significance under the null distribution to the shaded area under the alternative distribution. So I hope you can see my mouse moving, but you can see the shaded area to the left of the left curve for a one-sided alpha of 0.10. If we just extend that threshold up and now consider the shaded area under the alternative distribution, that would be the power for that particular test. Now, as I, again, reduce the level of significance, I'm reducing the shaded area under the null curve, which also reduces the shaded area under the alternative curve. So what I'm really doing, all other things held fixed, when I reduce my level of significance from 0.1 to 0.05 to 0.01, is I am making it harder to declare a winner, essentially, in both cases. So I make it harder to make that mistake when the null hypothesis is true, but I also make it harder to make a correct decision when the alternative hypothesis is true. And again, 0.05 is not a magical number. It should be based on the impact of making that particular error. Okay, so you may not think on a regular basis about how the level of significance impacts your power calculation or your sample size derivation, but you're probably all used to thinking about that difference, what that effect is that you're trying to decide. And I'm going to argue that, and as I demonstrated in that trial example from the New England Journal, the effect size that you're targeting should not be what you think you can induce with your intervention. It should not be what preliminary data suggests you will induce with your intervention, but it should be the minimum scientifically important difference. And that is the smallest difference which is going to result in a change in scientific practice or understanding, okay? Potentially there is some wiggle room in this if you are in earlier phases of study. Certainly if you're in a confirmatory setting, I think there is a very real risk, again, as you saw in that example, to designing a trial for the effect size that you think you can observe and not the smallest which would matter to your patient population. And there is a rule of thumb when thinking about sample size in terms of the effect size, and that is the larger the difference, the smaller the sample size. And that's sort of an intuitive concept, I guess. It oversimplifies the situation, perhaps, but the general idea is reasonable. So again, what I'm showing you here is a curve under the null distribution. I've shaded in the threshold for significance based on whatever alpha level this is. And now I'm going to show you the alternative distribution. So the curve that you see on the right looks like about a 1 unit shift, okay, from what we would expect under the null distribution. And you can see, again, the shaded region in that right curve would be considered the power. As the effect size increases, those two distributions are going to separate. And because of that additional separation, the power is going to increase. So when I move the effect size from 1 to 2, you can see how the shaded region increases, right? The area associated with that increases. And if I move it even further, again, you can see the shaded probability. Now, that's reasonable to think about in terms of the level of significance and how it plays in, but I think you can see even just by looking at the curves without thinking about the level of significance, that when the curves are closer together, there's less distinction between the two. And so when you obtain the result from your clinical trial, you're going to look at what you would expect based on those two distributions, and it's going to be hard to know which one you think it comes from, right? But as those curves separate and you get a finding, it's going to be very clear whether the result that you obtained is plausible under the null hypothesis or not. Okay, the other piece that you might be aware of that you need to factor in is the variability in your outcome. And what I mean by that sort of depends on whether the outcome is continuous or categorical. If your outcome is continuous, then you need an estimate of the standard deviation or the variance of that outcome measure. It helps if you're comparing two groups, if you have an estimate under both conditions, right? So whatever intervention that you're talking about might not just change the mean, it might also change the variation in the outcome measure, and it would be helpful to know that. If your outcome is dichotomous, meaning yes, no, alive or dead, something along those lines, then you need an estimate of the proportion of subjects in the control condition who will experience the event that you're talking about. And that will tell us about the variability in the response. So I mentioned earlier that this rule of thumb, the larger the difference, the smaller the sample size, really ignores the contribution of variability. So again, I'm going to demonstrate this with curves. I'm showing you two curves here, which have, there's a null curve on the left, an alternative curve on the right. They are, it looks like about 3 units apart in this case. And it seems like it should be pretty easy for us to distinguish, right, whether an observation is compatible with the curve we would expect under the normal distribution. But if I change the variability in those curves, right, so they're centered in exactly the same place, but the variability in them has changed. Now it becomes more complicated. Now I'm not so sure if I get a test statistic of 2, that seems pretty compatible with both, right? Certainly it's compatible still with the null distribution. So again, having some sense as to what variability you would expect on your particular outcome measure and under your treatment conditions is important. So, well, how important is it? Okay, so I'm going to show you some examples here. This is a continuous outcome. It's from a semi-generic phase 2 clinical trial on subjects with acute ICH. The intervention is intended to impact health-related quality of life. We're assessing that by the NeuroQual measure. We're assuming that the minimum clinically important difference on this outcome is 0.5 units. And what I'm showing you here in this graph are 3 curves that reflect the sample size along the x-axis and the power associated along the y-axis under varying variance conditions. So the red curve shows what the relationship between sample size and power looks like when the standard deviation is 0.5. So if you think about the standardized effect size, right? So the minimum clinically important difference divided by the standard deviation, this red curve is a very large standardized effect of 1. And you can see that we hit 80% power at somewhere less than 50 patients. The blue curve represents a standard deviation of 1. So our standardized effect size is now a half. And we don't hit 80% power until maybe 125 patients. And the orange curve is a standard deviation of 1.5, so a standardized effect size of about 0.3. And you can see now we're talking about almost 300 patients to get the same 80% power. So it really will make a difference in terms of the sample size that you derive. And so having a good sense as to what even ballpark those might be in, and you might consider estimating sample size under varying conditions so that you see, if I'm wrong, what sort of an impact does it make on the design I'm proposing? In case of the binary outcome I mentioned, we talk about variation differently. So again, this is a phase 2 clinical trial in subjects with acute ICH, but now our intervention is intended to impact functional independence, which is defined with a modified Rankin Scale score of 0 to 2. And we're assuming a minimum clinically important difference of absolute 10%. Those of you who do work in stroke, this 10% minimum clinically important difference on the modified Rankin Scale has been sort of a gold standard for a long time. There's now a push to use the modified Rankin Scale in more statistically efficient ways, but there have been many confirmatory trials who were designed with just this, under just these conditions. So with a binary outcome, what we really mean when we're talking about the variability is we need to understand what the control proportion is. And I'm showing you here, again, a curve that represents the sample size on the x-axis and the power on the y-axis, and shows you what that relationship looks like for varying control proportions. So the blue curve on the top is for a control proportion of 0.1. So if the control proportion is 0.1 and we want to increase the functional independence rate, we're talking about detecting a difference between 10% and 20%, okay? And in order to do that, we get 80% power at maybe 400 patients, okay? The orange curve increases the control proportion to 20%. So we're talking about detecting a difference between 20% and 30%. And we hit 80% power at just under 600 patients. And as the control proportion increases, the green curve represents 30%. So we don't hit 80% power until about 700 patients. And the red curve represents 40% in the control arm, and we're now up at about 800 patients in order to achieve 80% power. So as we increase that control proportion from 10% to 40%, the sample size that's required to achieve a given power is going to increase. What you're going to notice is that the variability in your binary outcome is greatest at about 50%, right? And you can sort of intuit why that might be the case. If you have a 50% good outcome rate, then you're basically saying, we don't know what's going to happen to this patient. We might as well just flip a coin, okay? So the sample size that's required to achieve a target power is going to increase until you get to somewhere in the 50-ish range. And then once you move past that and start going 60, 70, 80, 90, it'll start going back down again if you're detecting an increase, okay? So it's sort of this U-shaped relationship. Now, one question that comes up a lot, especially in phase 2 clinical trials, is that when we try to keep the sample sizes small, what the trials wind up looking like is an underpowered phase 3. And those are almost certain to get slammed for being such in grant review. And so one thing that has been sort of on the forefront a little bit more recently, in stroke at least, is this idea that we're not thinking about the phase 2 clinical trial correctly. We should be thinking about getting rid of interventions that clearly don't work instead of trying to design these underpowered phase 3s. And there is some sample size savings there. So what if you wanted to show that the effect is less than 10%? So if your alternative is that the treatment effect is less than 10%, and you can conclude the alternative is true, then you can say, I'm not interested in moving this forward to future study. And so what I'm showing you here, the graph on the left is the one we just looked at. The graph on the right is now under this new design where we're trying to discard an intervention if its effect is less than 10%. And the colors don't match, and I do apologize for that. So I'm just going to pick one. So the control proportion here, if I look at 30%, that's the blue curve, I get to 80% power under this new futility design at 300 something patients, maybe 375. Whereas when my control proportion was 30% and I wanted to show a difference of 10%, so superiority at 10%, I'm looking at somewhere in the range of 700 patients. Okay, so there can be a sample size savings, and it still allows you the sort of the practice period of making sure your randomization works, making sure the logistics of administering your intervention have been well played out, and things like that. Okay, so before you sit down to ask about sample size, you should be prepared to talk about the level of significance, the power, the variability. It's better if you have a range of plausible values from the literature, again, so you can do sort of a sensitivity assessment. The minimum scientifically important difference, and there is some back and forth. You may give the statistician the minimum scientifically important difference, and the sample size that comes back is astronomical. And so then you can go back and forth to come up with something that's justifiable. And there are some questions that you can ask about the experimental design that can potentially impact your sample size in sometimes a good way, sometimes not. But you can think about the controls that you're using. So do you really need a concurrent control arm, or can you make use of historical controls? Or can subjects serve as their own control? Now, in some disease areas, subjects obviously cannot serve as their own control. In some disease areas, historical controls, the data that's available through them is basically obsolete because treatment patterns have changed so much. So you do really need to think about those on a case-by-case basis. Are there multiple questions which can be answered in the same design? Is a hypothesis test the best way to achieve your goal? So if you really want to identify the optimal dose to move forward, testing of various doses with a hypothesis test is probably not the most efficient way to do it. If you have multiple interventions, again, that you're considering, hypothesis tests comparing all of them to each other may not be the most efficient way. There are selection theory methods that you can use. And how you go about all of this is going to impact what the sample size you come up with is. And again, the sample size calculation depends on the method of analysis. So if you're still hemming and hawing about which outcome measure you're going to use, or whether you're going to treat it as ordinal or continuous, or dichotomize it, or how you're going to use it, the sample size calculation, it has to know, you have to know that information before you can sit down and work through the process. No matter how you go through this process, you have to be able to justify the sample size, and you have to be able to do that in the grant application, and you have to be able to do it in the protocol. And in order to do that, you need to specify all of the key pieces that went into your sample size calculation, and your statistical collaborator can and should be able to help you with this. So how many subjects are you actually requesting? You want to be honest and upfront about whether the sample size is adequate for testing the hypothesis. In some cases, it's not, and you need to be upfront about that and demonstrate that you can still gain useful knowledge from this number. You want to give, like I said, all of the pieces about how the sample size was determined. Be explicit. If you need more, explain why you're not asking for more, and if you can answer questions with fewer, explain why you're asking for more than you actually need. In some cases, you can keep it small by studying a continuous rather than a binary outcome. Again, you saw how the sample size changes for varying control proportions, so you might need to play with that a little bit to see if that will actually work for you. But in cancer, for instance, they often use change in tumor size instead of recurrence. You may be able to study a surrogate outcome where the effect is going to be large. So you might look at cholesterol reduction rather than mortality. But again, this is going to be sort of disease specific as to what surrogate outcomes might be available and suitable for use in your particular area. Okay, in practice, how is this going to work? In practice, what probably most of your statistical collaborators want to happen is for you to come to us and we have a conversation that explains the disease area if we're new to it, that explains the treatment, that tells us what difference you want to detect, what variability you expect, and your target power, and we calculate a sample size. It can also, and sometimes has to work the other way. You may only be able to afford a certain sample size. And in that case, you tell us the sample size, you tell us the target power, you tell us the variability, and we'll calculate the difference that you can detect. But in either case, you have to be able to justify whether that detectable difference is meaningful, right? If it's so large that, you know, you're missing out on lots of potentially meaningful effects, that's going to be hard to justify. There are lots of sample size software options. There are some freeware options on the web, and I put the links in here. You can purchase software. So we have 3, I think, that I use regularly. Inquiry is one of them. I put the link here. PASS is available. We also have East, which does interim monitoring as well. And there are others that your statistical collaborators are going to have available to them. I'm pointing to the Iowa website because it's written there in black and white. And this is a statement that I agree with, but I would not have the guts to say on my own. So, and I can't remember the gentleman's name on the Iowa software website, but he says, I received quite a few questions that start with something like this. I'm not much of a stats person, but I tried XYZ. Am I doing it right? And he says, please compare this with, I don't know much about heart surgery, but my wife is suffering from XYZ and I plan to operate. Can you advise me? Okay, So there's lots of software options out there. You can plug numbers in and they're going to give you numbers back. But if you don't understand what exactly the numbers mean that you're plugging in, if you don't understand how it's using the data, some of them are making large sample assumptions to come up with the sample size. Some of them are making assumptions about constant variance between groups. If you don't know all of that, then just because you get a number back doesn't mean it's the right number, okay? So he advises, and I agree, find a collaborator, find someone at your institution or at an institution nearby, sit down and talk to them and develop a collaborative relationship. It will be good for both of you to come to a place where you speak the same language. It will only help your research program. Okay, so the last thing I just want to mention very quickly is related to the logistics, and we often don't think about this, but it does matter. So especially if you're talking about survival analysis, you need to have an understanding of the recruitment rate in order to come up with the sample size calculation. So how quickly are you going to recruit? That's going to depend on how many sites that you have. So if you don't have a sense as to how many of your particular subject type, your site or your other sites are going to see, and what the eligibility criteria are going to do to those numbers and so forth, then that's going to be problematic for the sample size determination. You want to have an understanding of treatment crossovers. In some cases, the treatment is administered very quickly and there's not a whole lot of room for crossover. In some cases, the treatment goes on every day for 90 days or a year. And in those sorts of studies, treatment crossover could be a real problem. And again, that's going to impact the sample size because it's going to dilute the treatment effect. The two arms are going to start to look more alike than they should. Whether or not subjects are going to have a hard time adhering to the protocol, or whether the sites are going to have a hard time keeping subjects adherent to the protocol, is going to impact your sample size calculation. And again, it's going to dilute the treatment effect in an intention to treat analysis. Do you expect a lot of loss to follow-up or consent withdrawals? Again, we have to inflate those because those subjects are still included under an intention to treat paradigm. And interim analysis. If you plan to look at your primary outcome early in order to make a decision either to stop for efficacy or to stop for futility, that has to be built into the sample size calculation because it's going to impact both your alpha level and your power. Okay, and so in order to keep those where you wanted them, you're going to have to inflate the sample size. So you want to think about those things. Maybe not at the very first meeting, except for the recruitment. If you're talking about survival, that might come up at the first meeting. These other things that are more inflations to the sample size that you derive through the software, that might be at a later meeting. But again, they're going to come into this process. Okay, so I'll leave you with some famous last words. R.A. Fisher is a very famous statistician who said to call in the statistician after the experiment is done may be no more than asking him to perform a post-mortem examination. He may be able to say what the experiment died of. Okay, so I'm going to stop sharing my screen. I don't know if it stopped or not, actually. And now, are there questions? I couldn't see the chat box while I was talking, but I don't see any notices in there. Are there questions that I can answer? Okay, so there's a question in the chat box. What if you don't have prior data to estimate the variance? How do you estimate then? Could you please give an example? So, yeah, I mean, that's a very good question. If you don't have prior data to estimate the variance from your own lab, you can use information from the literature. You may be able to take information on a similar outcome measure collected under similar conditions, maybe a device. If you're measuring blood pressure with a new device, maybe you can look at the variation associated with other devices that measure blood pressure. You're going to have to be probably a little bit creative. That's going to be a difficult thing to overcome. And in that case, you may not be ready to design a test for comparing those two interventions to each other, right? You may need to do a study to estimate the variance associated with your outcome, and that's okay. Not every trial has to be designed to detect superiority between two conditions. There's another question. If I decide my goal is a futility test, are the pieces of info I need going into the conversation the same as for a superiority test? Generally, yes. The pieces are going to be the same. You're still going to talk about the type 1 error rate. You're still going to talk about the power, the variation, the minimum clinically important difference. Pretty much everything is the same. The difference is that you, instead of thinking about the minimum clinically important difference as being the difference you want to detect, you think about a futility threshold, right? So you have to specify an effect below which you're not interested. And that may not be the same as the minimum clinically important difference, primarily for sample size considerations. Also, in the case of futility, the futility literature suggests that the alpha level that we typically use of 0.05 for comparing two studies in a superiority manner is not, I don't want to say it's not applicable, but they recommend a 0.1, a slightly higher, because you're more willing to tolerate a type 1 error. In futility, a type 1 error doesn't mean people are being exposed to an intervention that doesn't work. In futility, a type 1 error means that we're discarding an intervention that does work. And so from a patient ethics standpoint, we're more willing to tolerate that type 1 error. There is another question. Is sample size calculation necessary for a phase 1 trial focused on assessing safety rather than efficacy? The answer is yes. It's not as easy to do well, it depends. If you are evaluating safety on an intervention compared to a control, then much of what we talked about today holds, right? I would still be considered a phase 1 study, but a lot of the same information applies. If you're doing a phase 1 trial, say dose finding based on safety, sample size calculation is still necessary, but much more complicated. It's done through simulation, usually requires specification of various dose response curves for that safety outcome and so forth. But yes, basically no matter what stage of study you're in, you're going to have to justify the sample size somehow. When would you use confidence intervals versus p-values for hypothesis testing? So most folks rely on the p-value for hypothesis testing, right or wrong, that's sort of how it goes. A couple of exceptions to that are in the case of non-inferiority studies or futility studies. We often do that in terms of the confidence interval approach. As long as your level of confidence for the confidence interval matches the level of significance you would use for the hypothesis test, it doesn't matter. You're going to get the same answer. So it doesn't. I'm not sure there's a rule of thumb for when you do one over the other, but there are some design types which focus more on one than the other. There's another question that's asking for the best simple reference on sample size estimation. I've been avoiding that question because I'm going to have to think about it and look, but I will find something and I will send it out or I will get Joy to get it to you somehow. Other questions? You're all ready to meet with your statistical collaborators now? Hope so. Oh, are there trial designs when you want to switch? Haha, yes. The null hypothesis and the alternative hypothesis, and can you give an example? Okay, so in the superiority study, I want to show that my intervention is effective, that there is a difference between the two, right? And so my null hypothesis is that the two treatments are equal, and my alternative is that they're different. In some cases, you don't actually want to do that, right? You want to show that your intervention is the same. Maybe you've come up with a new formulation or a new way of administering your intervention, and you want to show that the effect is exactly the same as the standard. So in that case, your alternative hypothesis would be essentially that the two are the same, and your null hypothesis would be that they're different. You can't actually show that two things are identically the same. What you would do is to come up with a very small threshold of equivalence, right? So maybe you're willing to accept a 2% change over the previous one and call it the same. But yes, in that situation, you would essentially switch the hypotheses, and your test would reflect that. Then will that affect sample size then in a beneficial manner? My quick answer is no. It's going to make it worse. And it's sort of an oversimplification, just like the larger the sample size, the larger the effect, the smaller the sample size. When you're trying to show that two things are the same, the difference that you're willing to accept between the two is usually much less than the clinically important difference you would be trying to detect if you wanted to show that they were different, right? So if I want to show that my intervention has an improvement in modified Rankin scale 0 to 2, in stroke, I want a 10% clinically important difference. If I instead wanted to show that my intervention resulted in the same 40% MRS 0 to 2 rate that I'm used to seeing, I'm not willing to go all the way out to 10% and say that that's still the same, right? I might have to be within 2%, so 38 to 42. And then I would be willing to say that they're the same. And because that threshold is smaller, usually the sample size for either non-inferiority or equivalence is larger than it would be for a superiority study. That is not necessary, that is not true for futility. If you're trying to establish futility, I think the smallest threshold that you would probably use would be the minimum clinically important difference. You might pick something a little bit larger for sample size purposes, and because an argument can be made that in phase 3, you would expect the sample size to come down, or the effect size to come down even more. But no, unfortunately, I don't. Equivalence and non-inferiority are usually harder. Do you ever help to iron out the yes? Do you? Okay, sorry, Layla. Do you ever help to iron out the details of the aims page, translating aims into a testable hypothesis, dividing populations to avoid bias? Yes. So translating aims into a testable hypothesis, yes. We often spend a lot of time trying to really understand what the objective is and figure out how that fits into a testable hypothesis. Defining populations to avoid bias is a little more complicated. It depends on whether your statistical collaborator is familiar with the disease area. But if they are a clinical trialist, they should be asking questions about your eligibility criteria and saying, why are you excluding this patient population? Didn't you say that these are the folks you're most interested in? How is this going to be generalizable if you cut out all of these different subgroups? So yes, there is, if you bring your statistical collaborator in at the beginning, and especially if they are a trialist who is in your disease area, they're going to be working with you through this whole process. You're going to get to know them very, very, very well. Other questions? We have one more minute. I'll wait one more minute and see if one pops up, and then I'll let y'all go. When do you want to see the project? When you start thinking about the aims. So I work with 2 networks. So we see, for the networks, we see them very early. Outside of the networks, okay, well, I'll give you, for a large scale clinical trial at NINDS or at NHLBI, in order to submit those, you need to have approval from someone at the institute because they're going to go above a certain budget number. And all of this is going to have to go into that budget number. You're going to need to know how many subjects you have, all of that. So really, when you start hashing this out and thinking, gosh, I might be looking at a February submission, you should already be talking to your statistical collaborator, especially if what you're talking about is the clinical trial. Okay. If there are any other questions, feel free to send me an email. Otherwise, Joy might have something else to say before I let you go.
Yes, so thank you, Dr. Yeatts. I appreciate your presentation. I just wanted to make sure that everyone knew the evaluation link, which I just put in the chat box. So if you could just evaluate this webinar, that would be really helpful. But thank you, everyone. Our next webinar is next week at 12 o'clock. Thank you.
Thanks, guys. Have a good week.